President of Calicut Surgical Club. I warmly welcome all of you to the April Calicut Surgical Club meeting. Let us begin with a silent prayer. Thank you. Now coming to the minutes of the previous meeting. The last meeting was held on Thursday, 12th of March 2026 at KPM Tripenda Hotel with around 70 members attended. The meeting commenced with a welcome address by Secretary on behalf of our President. Following a silent prayer, the minutes of the previous meeting were presented by Secretary. This was followed by postgraduate presentation by Dr. Shaima Thomas, junior resident from Baby Memorial Hospital, on a topic, carotid body tumor. Then we had a senior faculty talk by Professor P.P. Lakshmanan sir, who shared his valuable memories and experiences from the past. The main presentation was delivered by Dr. Arun Kumar ML, who gave a video presentation on bile duct injuries, followed by an excellent talk on the importance of food, exercise, and sleep for the surgeons. It was truly an engaging session with active participation from the audience. The meeting concluded with the national anthem. May the minute be passed. Without any further delay, I invite our postgraduate presenter, Dr. Anshi A.K., for her presentation.
Good evening all. I am Dr. Anshi, General Surgery Resident, Aster MIMS. My topic is from impact to collapse, a silent year. I will be discussing about two similar trauma cases that presented to our ED recently within a period of 2 weeks. First case is a 21-year-old male, road traffic accident, car versus lorry. He was initially evaluated and managed at peripheral hospital. He was presented there in shock. Due to low GCS, he was intubated. After that, he developed a cardiac arrest, underwent 12 cycles of CPR, and ROSC were attained. Due to suspected cardiac tamponade, pericardiocentesis was done. About 15 ml of blood was drained and referred to our center for further evaluation and management. On coming to our ED, he was intubated and on ventilatory support. GCS was even VET M1, pupils 2 mm sluggishly reactive. BP was maintained on supports. There was tachycardia, S1, S2 heard, no engorged neck veins and no external hemorrhages. Chest bilateral air entry present, no external injuries and trachea central. On EFAST, there was pericardial effusion and free fluid in abdomen. CT was taken, which showed CT brain showed diffuse cerebral edema. CT thorax showed moderate hemopericardium with bilateral pleural effusion. And AST liver injury grade 3 with mild hemoperitoneum in CT abdomen. This is the echo showing pericardial fluid. This is the CT showing hemopericardium. There was sudden increase in pericardial effusion with unstable hemodynamics. A possibility of cardiac injury was suspected and he was taken for emergency exploratory sternotomy. Intraoperatively, there was massive hemopericardium, about 1000 ml of blood. Right atrial free wall with appendage rupture was noted, which was repaired using 40 polypropylene sutures. Mediastinal and pleural drain was placed, sternum closed with stainless steel wires and sternal lock plate. This is the intraop video showing right atrial wall with appendage rupture. Postoperatively, he was in ICU with ventilatory support. Due to persistent low GCS, MRI brain was taken, showed global hypoxic ischemic injury. Thoracic drains were removed on postoperative day 5, and tracheostomy was done on day 7 in view of possible long-term ventilation. This is the post-op X-ray. On bystander's request, he was discharged to outside hospital with GCS E3-VT-M1. He was hemodynamically stable. On BiPAP support, wound was healthy and sternum stable. Second case is a 26-year-old male, road traffic accident, bike versus lorry. He was initially evaluated at peripheral center and intubated from there due to low GCS and referred. On arrival to our ED, he was intubated and on ventilator support. GCS was E1 VET-M1, pupils bilateral 2 mm reactive. There was tachycardia and BP was maintained. S1, S2 heard, no engorged neck veins. Just bilateral air entry was present. On EFAST, there was pericardial effusion with free fluid in hepatorenal pouch. CECT thorax was taken from outside, showed moderate hemopericardium with contrast leak into the pericardial cavity, multiple rib fractures, sternal fractures and lung laceration and left hydropneumothorax. CT abdomen was taken, which showed AST grade 2 liver injury, and CT brain was normal. In view of moderate hemopericardium with active contrast leak, he was taken up for emergency exploratory sternotomy. Intraoperatively, there was massive hemopericardium about 500 ml. Right atrial rent near AV groove was noted, which was repaired using 40 polypropylene sutures. There was a horizontal sternal fracture at second intercostal space, which was fixed using stainless steel wires and titanium plate. This is the intraop video showing right atrial rupture near AV groove. This is post repair. Postoperative period was uneventful. He was extubated on postoperative day 1. Drain was removed on POD 3 and post-op echo showing no residual pericardial effusion and normal cardiac function. This is the post-op X-ray. He was shifted to room, mobilized well, vitals were stable, wound healing well and discharged in stable condition. Blunt cardiac injury is an uncommon but potentially fatal consequence of trauma. Survival depends upon early and high suspicion, rapid diagnosis, and immediate surgical intervention. Cardiac chamber rupture represents about 0.041% of all trauma cases, with overall mortality rate of 89.2%. Injury to the heart is involved in 20% of road traffic death. Chamber rupture is present about 36 to 65% at autopsy. Chamber rupture or perforation carry a high mortality rate and patient rarely survive long enough to reach hospital. A retrospective analysis by Texera et al. Of blunt cardiac trauma autopsy findings revealed that the right chambers were the most frequently injured cardiac chamber. Right atria 30%, right ventricle 27%, left ventricle 19% and left atria 17%. Clinical presentation often non-specific and masked by polytrauma. Classical Beck's triad like hypotension, raised JVP and muffled heart sounds are present only in less than 50% of the cases. So always suspecting persistent tachycardia, unexplained shock and rapid deterioration. Mechanism of right atrial rupture. Right atria is most anteriorly placed and thin-walled chamber. with low intracavity pressure. Shearing associated with the rapid deceleration causes disruption of veno-atrial junction, and it can compress between sternum and vertebral column. There is a phenomenon called water hammer effect, that is, sudden compression of abdomen and lower limb causes increase in venous return, which causes acute rise in atrial pressure causing rupture. Key diagnostic tools are EFAS, which is first line bedside tool, and detect pericardial effusion. CT scan has increasing role in stable patient, and findings are hemopericardium with contrast leak into the pericardial sac. Echo confirms the effusion and chamber function, limited in unstable patients. Once diagnosed, immediate surgical intervention is mandatory. Options are emergency thoracotomy in ED setting and median thoracotomy preferred in OR. Blunt cardiac rupture is rare but lethal. Always suspect in high impact chest trauma with unexplained shock. High suspicion, EFAST and early sternotomy is life-saving. In trauma, the heart may fail silently, but rapid diagnosis gives it a second chance. Thank you.
Was there any external injury in this patient?
Sir, first patient has no external injury. Second patient has abrasion over chest and multiple rib fracture, sternal fracture, and
any associated injuries like head injury and liver and colon, etc. Only pure heart disease.
In both cases, liver injuries was there and brain was normal in both cases, sir. Because he was in persistent hypertension and
so many other reasons for hypertension. Why should you suspect cardiac injury?
EFAST show pericardial effusion, sir.
EFAST. That facility is available.
Yes, sir.
Have you heard about a cardiac box? Cardiac box.
No, sir.
It's an area where there is an injury bounded by sternum and this manubrium and the right, both mid-clavicular line. Suppose there is injury, you have to think possibility of cardiac injury. Which is the postmortem says that it is a 20, more common is right atrium. Whatever the literature says.
There was no specific literature available, sir. Journal says right atrium is more common.
I think it is right ventricle, I think, most common.
In autopsy, maybe.
No. Suppose it is aorta injury, which is the commonest site actually. If it is an aorta, arch of aorta.
Disruption from aorta,
The commonest
right,
site.
left atrium. Arch of aorta.
Arch of aorta, I'm asking about arch of aorta, the site. It is distal to the origin of left subclavian actually, it's a common site. How will you differentiate this arch of aorta injury? Clinically, can you differentiate other than pericardium?
Peripheral pulses.
Which peripheral pulse?
Femoral.
Femoral will be absent or
Absent
low
or
than the upper limb
upper
pulses.
limbs.
X-ray detects external fracture. How will you manage?
When it is undisplaced, there is no need of intervention. When it is displaced, we should fix the sternums.
How will you manage? Means what are things you will look for?
We should look for a cardiac injury, major vessel injuries.
So what will you do? You will let the patient go to his room, or you will get the patient go home, or what?
We will admit the patient and monitor
What will you monitor?
vitals.
Okay, you will check BP, pulse, or what else? What is one major issue that can occur with sternal fracture? Arrhythmias. It has to be on continuous ECG monitoring. Of course, the tamponade, all this cannot come.
Thank you, Anshi. For a change from the usual senior faculty talk, I felt it would be refreshing to highlight many talented young surgeons around us who have remarkable passions and beyond surgery. With that in mind, I have planned a new session focusing on the artistic side of a surgeon. Today, we have with us truly gifted individual, an artist not only in painting, but also someone deeply passionate about designing, music, and reading. His enthusiasm is so profound that he even has a 3D printer in his bedroom. Just imagine that level of dedication. It gives me a great pleasure to welcome my dear friend, colleague, brother, our very own treasurer, Dr. Umar Fadil, for a short presentation on his passions.
Good evening, everyone. I'm Dr. Umar Fadil, currently balancing surgery and slightly obsessive interest in drawing and painting. And I have to admit, I'm still not entirely sure how relevant this topic is to a surgical club, but I'm here anyway, thanks in large part to the constant encouragement from Dr. Dinulal and Dr. Srijayan, who clearly had more confidence in this idea than I did. So I'm Dr. Umar Fadil. I did my MBBS from Calicut Medical College, 52nd batch, 2008 admission. And I did my PG from KMCT Medical College. I was the first DNB candidate there. And now working as an assistant professor in KMCT Medical College. And my areas of interest, apart from this academic interests, are creative art, technology, and music. So I'll be talking something about the creative art part of this area. So you'll have to bear with me for next 5 minutes. So how it all started, the art journey. So I was always interested in art, creative art especially, from the childhood itself. And I haven't had any formal training. And I started drawing during my final year MBBS. So that was through a Facebook post. I did some drawing and posted it on Facebook. And I got some good comments, and that motivated me further. And it was initially with the graphite pencils only, that normal pencils you can see, HP 2B pencils. I was using that only. Then changed to colored pencils, which was my forte. So, and then I started collecting art supplies obsessively. So, I procured the initial art supplies, graphite pencils and colored pencils from local art supply stores. But it often stocked only student grade supplies, so I have to go online and start searching. And it was the time, that 2014 year, that online shopping boom was happening in India. Amazon was just launched, and I got the information that a brand of color pencil is available that is very good for colored pencil artists. So I went ahead and bought a small set, 48 set, and it was the real starting point for my art journey. So it is known as a Prismacolor pencil. It is mainly manufactured in USA. So this is the first, one of my first drawings that I've done using that pencils, Prismacolor pencils. So it was, again, I posted it on Facebook, and some major art page was sharing this post, and I got like 20,000 likes at that time. So this was the initial, one of my initial drawings. And this is a recent one. I drew it around 6 months back, again with the same pencils. So I'm using the same pencils again, and that is my favorite brand of pencils. So, talking about my inspirations, this is a person most of you may not be knowing. He's Marcello Barenghi from Italy. And the right image that he's showing is a drawing of his drawing that is done by him. And he's holding the bottle, real bottle in his hand and next to his drawing. So you can imagine how talented this person is. So this person is actually my initial inspiration. So this was the image, drawing done by me after getting to know this person. So I posted it on a social platform for artists known as DeviantArt. And this post got some attention, and this person, Marcelo Barenghi himself, texted me and advised me to start on a YouTube channel. He was already having a YouTube channel at that time in the initial stage. So he himself told me to start a YouTube channel. So I started a YouTube channel back in 2014. So my first upload was in 2014 during the break after final year MBBS exam. So I was, the time was plenty, and I had some resources. So I started posting YouTube videos. And initially it was simple still life drawings and barely, immediately House Agency was following. So I got little time, and with the little time I got, I drew a lot of pictures and made it into videos and released on a weekly basis. And during that time, I posted in S6 unit surgery with Dr. Srijan sir and team. Dr. Bashir sir was also there. And this was the defining moment for me during my surgery posting. Dr. Srijan would actually sit and watch all my videos, and probably my most loyal viewer at that time, and probably and keep pushing me to create more. And I was so happy during that phase. And in fact, that posting quietly convinced me to choose general surgery for my post-graduation. So I'll show you a video. This is my first YouTube video, a drawing of a pear. You can see that the video's quality is very bad. It is the first video, and it is very shaky because the camera and that DIY tripod I was using. It's again done using the same pencils I've mentioned. So this was the final image, and this was my first video upload. And these are some of my initial drawings. I'll show you. This is a gemstone, again drawn with the same pencils. Some still life images like burger and apple and all. These are all posted to YouTube at that initial phase, and it actually helped me grow the channel. And again, I forayed into drawing portraits then, apart from still life, and discovered the true joy of drawing portraits with colored pencils. And it is actually much more challenging and time consuming, but it was very rewarding. So this was my first portrait that I posted on YouTube. Again, it was a traditional art version of Anna Dittman's digital painting. Anna Dittman again is a famous digital artist, and she herself commented on the picture, and I was fortunate enough to get that comment. This is again a drawing video of that same picture. Again, bad quality camera back then. Then this is again, I've done it using only colored pencils. This is a portrait. I've taken like 20 hours to draw this one. This is actually the most time-consuming one I've ever created. Again, the same. This is the video showing the drawing. Initially, I posted these time lapses to YouTube, not with any audio or anything, just time lapse videos of the drawings. This is another portrait, again, a traditional way of, a traditional take on Anna Dickman's digital painting. This is some other portraits. This is done actually using markers, not pencils. Again, markers. Markers and some, this is actually mixed media. I've used markers, pencils, and some white gel pen, I think, for the details. Then I started posting tutorials with voiceover. This is the time when the YouTube channel actually got attention. There were some realistic portraits and basic drawing tutorials which got popular. And this was one of the most popular videos I've uploaded. This got like 4 million views. And these are the media that I use usually. And my favorite media is, of course, colored pencils and watercolor. Then others I have used acrylic, oil, pastels, then alcohol markers, and I usually mix them all together. And most fun I'm having is doing mixed media. So this is a mixed media art. Again, I've used watercolor, colored pencils, acrylic, everything on this one. These are done using alcohol-based markers. This is acrylic. This is a small painting, like A4 shape. This is done in oil painting. This is also a very small painting. So these are the media that I use. Usually the Prismacolor pencils I have mentioned. Then I use Winsor & Newton artist grade oil colors. Then Faber-Castell Polychrome. So there are so many brands, Liquitex, acrylic. Then watercolor I use is Daniel Smith. And so many markers. So the take-home message is you don't have to gift me anything like art supplies because I have a ton load of art supplies in my home. So some of my proud moments, I got this YouTube play button, silver play button by reaching 100K subscribers by 2017. And one of my works got featured in Colored Pencil Magazine USA in August 2019 edition. And these are some of my proud moments. And this is the current status of my YouTube channel. I've uploaded like 3 years back. I've actually got lazy and I have to upload again on the same channel. 3 years back, I think 2 or 3 years back, I've uploaded the last video. Okay. So, thank you for hearing.
Only today I know that I am working with Vincent Van Gogh East. Congratulations.
Fadil, I never knew that you were having such a gifted personality in your. But I think you will be able to make more money out of this than what you are earning from your profession.
So
I think I think you must have had, isn't it?
Yes.
Okay.
I was getting revenue from YouTube only.
Okay, okay.
Okay, thank you.
Thank you, Fadil. Next, when discussing about the thyroid gland, one topic that is both fascinating and often confusing is management of papillary thyroid carcinoma. Some of them doing total thyroidectomy, some hemithyroidectomy, some central neck node dissection, some MR&D, berry picking. So to help us understand the current guidelines in the management of papillary thyroid carcinoma, we have with us an expert from our own city. It is my pleasure to welcome Dr. Sajid sir, head and neck surgeon at the Calicut MIMS Hospital. So he completed his MBBS from Government Medical College Calicut in 1995 and MS ENT from AFMC and completed his DNB and fellowship in head and neck surgery from Regional Cancer Center, global online fellowship in head and neck oncology by International Federation of Head and Neck Oncology Society. He has extensive experience in head and neck surgery. He is a former professor at Malabar Cancer Center. He has presented at more than 50 conferences, published 7 conference abstracts, and authored 48 scientific publications. He also co-authored a chapter on oral and lip cancers in the textbook of Essentials of Head and Neck Cancers, edited by Rahan Kazi and published in 2011 by Byword Publications. Welcome you, sir.
Hello, 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 hello. Really fascinated by seeing Fadil, right? Okay, I think should get the name first because I've seen my daughter doing such things and then was thinking, and we used to have those warm moments when, especially when our daughters do that. And then today I had so much of that. Very lucky day for me today because I'm standing in front of my so many UG teachers, Joji sir, Govi sir, Lakshmanan sir, Rajan sir, Mohandas sir, and I think only very few are missing like Rajan sir. And I'm feeling the same nervousness that I used to have while standing in front of those Viva sessions. And I think today I will learn more from these stalwarts than I will tell something to you all. Okay, so I am sure you will give the same pass mark out of empathy and sympathy that you used to do during that time rather than my intelligence. Thank you. And thanks, Surgeons Club, for inviting me and giving me this opportunity. We all had done, like Fadil was doing some fantastic job in his life, and then we probably, many of you would have done so many heroic things in your life. I'm sure the surgeons will have enough number of heroic things that you do in this light on in this like in our life. So that is one of my patients whom I always remember when I think of thyroid surgery and the heroic thing that I did long back. Like not long back, maybe 10, 12 years back. And he was a 47-year-old gentleman who presented with that swelling in the neck, which you can see here. But he was carrying it for the last 15 years. And he was not mindful because it was not giving him any symptoms. And then because of that recent change in voice, he came to us and that FNAC told us it was thyroid cancer. It was a papillary cancer. And when we closely examined, that was the mass in the right lateral neck. So we were a little confused whether it is a node or the thyroid, and it was fixed. There was no movement at all. So again, we had a confusion as to what was that. And that was when we took this scan. And of course, as expected, we could see that there was a large mass arising in the thyroid bed on the right side. And on the left side, what I am showing is the internal jugular vein. So we can see that the internal jugular vein is engulfed in the mass, and also probably the carotid on the other side and carotid on this side. And I don't know whether Dibin was there at that time when we did this surgery, 2014, 13, 14. probably. And further, we took an MRI to see whether the vessel was actually involved in this, and then we could see that this mass was totally engulfed with thyroid, in the thyroid. So I was young, enthusiastic, and surely we were thinking, okay, whenever we need to treat thyroid, we need to treat with surgery. And then I took the help of cardiothoracic surgeon, and then we decided we'll resect the carotid. My first ever experience, going to be resecting the carotid and removing the entire thyroid and mass in this patient. So we planned for carotid bypass. I think Dinraj gone. I think for him it would be a very easy job, but for me it was a very very difficult and unthinkable thing. But the cardiothoracic surgeon was there with us, and we went ahead with the plan of operating him. And he also had some mediastinal nodes, lung metastasis, etc. And with the other, our surgical oncology team, we went ahead with this surgery, wherein we opened the entire area, and with great difficulty, we could separate the carotid from the mass. We were going very slowly, it took hours, as you would expect, but then we had to resect the subclavian and put the graft, and other mediastinal nodes and lung nodules were all removed. So it was such a heroic surgery. I could, every year I would look back my photos, because I have the habit of taking photos. I would look back the photos. Whenever I get depressed, I will look into these photos and get fascinated. Okay, I did something great. I think many of you would have done that many a times. Okay, if not your picture, if not your drawing, it is your surgical photos. And this is this patient, and then we gave radioiodine therapy. And this patient has been following up with me for the last 14 years, and he is still alive without much issue and happily living. Has I think that last photo did not come. I was showing that photo with his grandchild. Okay, so that is how thyroid surgery works. I am sure that all the seniors would have seen many of these kind of patients, and this is another scenario wherein the thyroid has engulfed or infiltrated the trachea. Here, this was my, I think, largest tracheal removal along with this, because we had to remove 5 cartilages. Usually it is a little difficult, but later I have done, for these kind of patients, 5 cartilages. And that is and then further cricotracheal anastomosis was also done. And this patient is also surviving without much issues. So some of these heroic or probably difficult scenarios do give us good results. It is not that they don't do well. Other examples like laryngeal cartilage and pharyngeal invasion, there also we would go ahead and do the entire resection, and then these patients do survive well. And this is my only patient whom I had to remove the larynx, because removing larynx for thyroid is not so common. And this is one patient whom we had to do the laryngectomy. You can see the stoma there, and she is also surviving. This was done in 2012, and she's still surviving. She is coming for follow-up to my OPD in Kannur. And so such bigger resections really gives good results in thyroid. So it is not that they have little difficulty. So from very radical surgery to an adapted precision care, we can give good survival to thyroid patients. But there is a paradigm shift of doing some de-escalation. Which are these patients? That's what we are going to see today. It is not these patients whom I have already explained. So if you see, over the years, the thyroid surgery has evolved. Many things have got added. Initially, people had been doing radical surgeries, then came up radioiodine therapy, and then slowly, when the American Thyroid Association guidelines started coming, people started thinking, should we do that much? And then that is how, from 2015 onwards, these kind of de-escalations has happened over these years. So why we should think of something like de-escalation? It is because of this graft. I think all of you know, over the years, there had been an increase in thyroid incidence of thyroid cancers. But when they looked at the mortality, it has remained at very low level. There is no change. So even though the number of patients increased, the people surviving have increased, there is nothing much in that way. So 30 years, it has tripled over the last years, and mortality is only 0.5 per 1 lakh. So why it is so? Because all those new incidences are those patients which are those tumors which are very small. And what is the other problem is the surgical mortality of overtreatment. And why we could pick up all these small tumors is because of this high resolution ultrasound, because of the number of ultrasound being taken for various reasons. Recently, last week, one of the patient came and she went to the ENT surgeon because she had something mass pulsating here. And the ENT surgeon, okay, it is pulsating. It is understood it is the innominate artery, high-riding innominate artery. But he took an ultrasound, and in the ultrasound there was a 5 mm thyroid nodule, FNAC, proved to be papillary carcinoma thyroid. Now we are planning surgery in the coming days. So this is a common scenario, and I'm sure all of you would have surely seen those patients. And in addition, we get lots of patients due to incidental detection. This is one of the scenario which I told. Another scenario in oncology is, I think, again, Dibin would agree, when we have surveillance scans for some of our patients, like breast cancer patients treated and completely cured, when we take a PET scan for survival or for surveillance, we would see that there is a focal uptake in the thyroid. So then we would follow, because the patient is still surviving, he has been cured of some cancer, we need to take care of this nodule. Then some patients do come like that. So those incidental, and one of the surgeons from US who is known in thyroid field, Dr. Ashok Shaha, I think many of you would, I don't know whether you would have heard, he used to tell this is a pain because it is PET associated incidental nodules. He used to call it like that. So it is a pain sometimes because we do not know whether we have to treat or just observe these patients. And so the escalation which has happened, de-escalation which has happened in all the modalities or all the situations where we treat or diagnose or treat these thyroid cancers. We are trying to do lesser diagnosis, we are trying to do lesser surgery, less of radioiodine, something on monitoring also. All this we are trying to de-escalate, mainly because we have understood these thyroid cancers much more better. I think I have taken, one second, I've taken the older version. Well, give me 1 second. Okay. You might see some repetitions because some of the slides I had changed. Okay, so that is the reason why we should start thinking. Now I have told about these large cancers, infiltrating thyroid cancers, and should we do some de-escalation? I told even by doing that much of radical surgery, these patients are surviving. So this treatment of these cancers remains the same. I had a slide for that. I think we missed on that. This was the slide. Okay. Yeah. So all these guidelines from one is from the American Thyroid Association. They clearly says that in infiltrating locally invasive thyroid cancers, we should go ahead with this radical surgery. So there is no de-escalation. Okay, so this is mainly to get into your mind that all these radical surgeries, we need to do radical surgery, no de-escalations in these tumors that I brought in these initial pictures. Now, this is Japanese version. Again, they say we need to do radical surgery. If you see other guidelines as well, and NCCN guideline, they also support doing surgery for all these tumors. So that is a graph. And now coming to the lesser invasive tumor or a lesser version, a thyroid cancer with a neck node, should we do some de-escalation? Again, here also we know that they are large tumors or advanced tumors, and they will have some of them will have nodes. What we should do is we should go and detect those nodes. Many times, sometimes we see that some patients who get referred from outside after thyroidectomy, and when we palpate, we see that there is a node. Some people still miss in the periphery, that they miss these nodes. So I think for differentiated thyroid cancers, especially papillary carcinoma, whenever there is a diagnosis, we should first go and see whether there is a node in the neck, and that should be managed correctly. So there is no de-escalation, but there should be a careful selection. And whenever there is a node, we should do what is known as the compartment-oriented selective neck dissection. That is, we need to do levels 2 to 5, and clearance has to be there. I think that is the regular teaching, that we shouldn't do a berry picking in these patients, and we should remove those nodes. So the recommendation says, in this American Thyroid Association guideline, which has come in 2025, and I think it is in the same as the other area, lateral neck dissection should be done whenever node positive. But what about the central neck dissection? That is where they would concentrate and do some de-escalation. They say we don't need to do prophylactic central neck compartment neck dissection, especially for all the early T1 and T2 tumors, because there is high chance of morbidity associated with it, and we should be more selective in doing central neck dissection. So till now what I said is infiltrating thyroid tumors, we shouldn't do de-escalation. Whenever there is a thyroid with neck node, we shouldn't do de-escalation. We should go and do the full surgery at one go. Whereas when you think of a scenario in which there is a small tumor in thyroid, should we do a prophylactic neck dissection? No. There used to be a situation where people used to do left and right central neck dissection, and then hypoparathyroidism used to be very rampant or very high. And now they clearly suggest if it is T1 or T2 tumor, that is less than 4 centimeter tumor, you don't need to do central compartment neck dissection unless there is an extrathyroidal extension, because size does not mean that they may not go into an extrathyroidal extension, or if you really see that there is a central compartment node. The problem with central compartment node is that it will not be picked up in the initial ultrasound scan, which we usually do for thyroid. So that is the reason we have to be little cautious in doing a central neck compartment neck dissection. Whereas if you take up those bigger thyroid tumors, like more than 4 centimeter, or with patients who has those lateral neck nodes, if the patient has got already lateral neck nodes, even though there is no central compartment node, that central compartment has to be done. That is the current recommendation. I think it has been there for a long time now, and the therapeutic central compartment is for all clinically involved nodes. But how do we understand whether there is a clinically involved node? That is the question. I said ultrasound will not pick up. Then the current recommendation is that in all these patients where there is a higher chance of central compartment node, we have to go and examine this central area. We examine the central area. If needed, we can do frozen section of those nodes if there are some picked up nodes, and then if it is positive, do the complete central compartment neck dissection. Otherwise, just leaving it is also not a good idea. As I said, lateral neck, in lateral neck, we need to do central compartment neck dissection along with it. In early T1, T2, we should not do, and in advanced tumors, we should think of central neck dissection. Now coming a little further down, we talked about infiltrative thyroid cancers. We shouldn't do this de-escalation. Lateral compartment nodes, we shouldn't do. Central compartment, we should select our patients well and do the neck dissection. Now, further down, in a patient whom we have done total thyroidectomy, what are the other treatments and other de-escalations that we can do? This chart has been included now. I think even in 2015 guideline, they used to have a risk stratification guideline. This is a chart which will say about what is the risk of recurrence after an initial therapy. And according to that, we need to decide whether the patient should get a radioiodine treatment or not. So, if the patient is not having an infiltrated tumor or a neck node, these two patients fall into high-risk categories. That is, infiltrating thyroid cancers or neck node patients. Large neck node patients fall into high risk or even intermediately high. They should get radioiodine therapy as an adjuvant therapy. Whereas, what about other patients? All the other patients we should see and decide. The habit of sending all the patients to nuclear medicine department and ask them to continue therapy or follow up should be, I think, curtailed. It is what these guidelines say. It is not from my words, okay? So they shouldn't come back behind me. We should assess. We should have a risk assessment. So I think that is how we do in our OPD. Like whenever the patient, after the first follow-up, after the suture removal, etc., we will sit. I will open this risk stratification guideline in front of the patient and then tell them with the histopathology. We will discuss with them. And this is the scenario. You fall into low risk, high risk, or intermediate risk. So we have to do a risk stratification. First of all, we have to do. I think, sir, in your departments, I think the same way you would be following, or you would be referring to nuclear medicine and they would take a call. Usually, what would be what is the principle now? Just to, after thyroid surgery, I think everybody is thyroid surgeons, surely. We have learned and seen thyroid surgeries from you. What about others like, did you? That's what, that I know, because that's the usual practice. I think if you send, I think mostly they will do the therapy. That's the usual practice that we see. But time and again, in 2015 guideline and in 25 guidelines, it is clearly said that we need to do a risk stratification of these patients. Based on this one, and this is they have given it as a recommendation itself, recommendation 21, that we should do a risk stratification. And then, all this, who should get radioiodine therapy is those patients with high risk. And they clearly say, if the patient has got a low risk differentiated thyroid cancer, they should not get radioiodine therapy. Similarly, if the patient is having low intermediate or high intermediate, we may consider it. That's it. It is not that absolute necessary. And if it is a high risk thyroid cancer, or if the patient is having metastasis, then these patients should get a radioiodine therapy. Like my initial patients, all of them got radioiodine therapy. So probably half work is mine, surgery, and half work we can say that radioiodine would have helped surely in giving them survival. Whereas these low risk patients, because low risk means they have smaller tumors, they have smaller nodes. Even if they have nodes, we do not need to give them radioiodine, but usually we slightly weigh on that, because if the patient is having some nodes, we would usually send them. But all those patients without nodes, we would surely say. Because all patients with nodes will fall into, larger nodes will fall into intermediate grade. They say that you may consider radioiodine therapy, But when it is infiltrating thyroid or larger nodes, more than 3 centimeter, they will surely get radioiodine therapy. So this is that criteria. Why? Because the chance of recurrence in uh, high risk category is 30, more than 30%. So we should give them. This is based on this trial, estimable trial. And the intermediate to high will have 16 to 30. Low intermediate will have 10 to 15, and low risk has less than 10. But always, I think in our practice, because these guidelines are mainly for them to mainly treat based on the insurance, whereas in our practice, sometimes we may suggest, and by our unluck, this patient will go to a nuclear medicine specialist and get an opinion, and they'll say, oh, you did not get, or if by our unluck, if the patient develops a node, surely they will say, oh, you did not get, that is the reason. This has happened in my practice also. I think many of us would have heard the same. So that is why we discuss with the chart and then take a common decision. Because some of the patients who are coming from Gulf are not there for follow-up. Sometimes we may have to overtreat these patients, but with their consent only, because we need to see them. Now, this is what high-risk categories means. These are the surprising ones, because I told you, once the patient comes back to us with this histopathology, these are the surprising ones. Because we got an FNAC of papillary carcinoma, we knew that these patients are 2 or 3 centimeter thyroid swelling, we did a total thyroidectomy. But when we see the report, it may be these kind of high-risk categories. Like one of the patients we had was diffuse sclerosing. She was a dental surgeon, wife of a doctor, and then she's been followed up for last 4 or 5 years. Until now, nothing. But she got radioiodine therapy. You can see that lymphatic invasion, etc., in these kind of patients, and that was a diffuse sclerosing variety. So if you get this, surely we need to treat them with radioiodine therapy. This is another unlucky patient. She who had obesity. She was doing a regular checkup. She found a thyroid swelling, and we did a total thyroidectomy. And the final report came as hope-nail. You can see these kind of cells in this patient. And this is a hope-nail variant, again an aggressive version. They will get radioiodine therapy after a good thyroid surgery. Again, third patient is a tall cell variant. This patient we had been following up for the last 4 years. These are all MIMS patients. That's why I could get the slides. And this patient is also not having any metastasis. Though we say that they are highly aggressive, these patients in the recent years, they have been going well. And one ablation radioiodine were received in these patients. So we need to identify these high-risk tumors, even if their size is smaller. And why we should select and give these patients? Why there is a change from 2015? What will happen if we give radioiodine therapy? These are these things. Even though we don't see it commonly, some of these patients do develop a xerostomia because of the sialadenitis. Some of these patients, when they checked, Ian Nexon's paper is there, when they checked that from 1970s onwards, when they started radioiodine, and they had 50 years of data, and they found that many of these patients did not get benefit from radioiodine therapy. And their second primary cancers in that group who received radioiodine therapy was higher than the normal population. That is little alarming. I don't know whether you would have seen. I've been following up my patients myself rather than like an endocrinologist or nuclear medicine. So in the last 18 years, I have the follow-up of patients, but none of them we have seen these kind of second primary tumors. But it is the literature report that says. So that is little alarming. So should we give or not? That is always a question. Now the argument from the nuclear medicine people is that the small dose that they give for remnant ablation is not going to cause anything. It is only the high dose which is going to cause again. But if it is not going to benefit, that is all the trial says. Even a phase 3, Istanbul trial was a phase 3 trial. it shows that there is no benefit. Then why should he give? So that's the question. Now, I told you, infiltrating thyroid cancers, large nodal metastasis, or very high aggressive variants of thyroid cancers needs a good therapy, a good radioiodine therapy, and we can always select. But what about this classic papillary carcinoma thyroid? FNAC is papillary carcinoma. Final report also says classic variant. Now, that is a question. Do we all see whether it is a classic variant, or just see that, okay, it is papillary carcinoma and then forget it? We should look. We should ask our pathologist to write whether it is classic variant or not. If it is classic variant, then what will you do? All these trials, I think you won't be able to read. It is ITO from Japan, ADAM, Istanbul trial against ION trial, Miyauchi's, many of them did studies and found that, yes, we can do lesser. Even we can do lesser surgery. This is the real de-escalations that we try and do. Total thyroidectomy is required in whenever I said all those big aggressive things are not present. Total thyroidectomy is required only if the tumor is more than 4 centimeter. If there is gross to extrathyroidal extension, if the nodules are bilateral, or if there is nodal metastasis, or even distant metastasis, or sometimes, as we said, aggressive histology. And another variety is where there is if there is a radiation history or familial association. If none of this is there, can we do something lesser? So, recommendation 15, this is from the 2025 ATA guideline. Recommendation 15 says, all these patients with low risk, with unilateral thyroid cancers, 2 to 4 centimeter, that is, they will fall into T2, N0, M0. Thyroid lobectomy may be the preferred initial surgical treatment. In the previous version, that is 2015 version, they did not mention this. This is the new addition that they have brought in, that even in 2 to 4 centimeter, without much risk, we can do thyroid lobectomy. And this is one of the index, one of our patient. I think you may, some of you might be knowing him. I won't take the names. He is a doctor himself, and he had a 3.5 centimeter tumor, and we did only a lobectomy, and we are following up him. He had a classic variant. There was no other features except for one vessel invasion, which is also a smaller risk. Now, what about still smaller tumors? Because that is what usually we see. Many of our patients might have less than 2 centimeter tumor. So if we can do it for 2 to 4, surely there is no doubt at all. We can do it for lobectomy. But here, what they say is, when resection is performed for patients with thyroid cancer less than 2 centimeter without all these features, without metastasis, etc., the initial surgical procedure should be, they said it should be. We should not do total thyroidectomy. We should do only lobectomy. They have clearly underlined it should be. Now the question is whether can we practice this in Indian scenario is our call. We have to discuss. We have to tell to the patient also the things, and the decisions can be taken. Again, another patient, 33-year-old doctor, because this criteria had come in 2015 itself. So I had been practicing from 2015 about this, and this patient came, again he is in Calicut area only. He came in to Malabar Cancer Center at that time, and he had a 1.2 centimeter papillary carcinoma thyroid. We did hemithyroidectomy in 2019. That was in 2009, not 19, it was in 17, sorry. And so he is on follow-up, and until now there is no issue. Only thing is these patients needs follow-up. Why? If you see, both my patients were doctors. both my, or even sometimes some of them would be doctors' relatives, because we have to make sure that they will come for follow-up. We have to make sure that they understands the disease and they understands what we tell them. So in this recommendation, they say, if you say that the patient is a candidate for hemithyroidectomy or a lobectomy, and we have discussed, they agreed, always say that there is a possibility of conversion to total thyroidectomy, because sometimes we may be deceived. It has happened in few patients in our hands as well. These were the examples, wherein one patient, again a dental doctor, had a thyroid nodule of 1.5 centimeter. So we discussed and said the FNAC was papillary thyroid cancer. We did right hemithyroidectomy, everything well. You can see this is the nodule. I had a little doubt that it is coming into the capsule, so I did the central compartmental clearance on that side also, but those nodes were negative. And you can see the margin. Whenever we do hemi, we have to make sure that we get a good margin around. And we got a margin. Everything was fine. But this was my pathologist colleagues. That's why we don't like pathologists sometimes, because they give us bad things sometimes. And that is what she said. She said, I think I'm happy that Rajan sir is not here. Because ma'am only gives those reports, sir's wife. And so this came as poorly differentiated carcinoma. This is a newer entity which has come in the last WHO classification. WHO classification, I think 2022, I think. They have included these newer variety. They have given so much classification by which, criteria by which they have to call them poorly differentiated. So here you can see vascular invasion and these invasions, and that is why they called it poorly differentiated. And now that is a little aggressive and having higher mitotic activity. And that is another point. If your pathologist is not mentioning mitotic activity, please tell them to do so, because that is a mandatory now. I think all pathologists follow those guidelines usually, but we should also keep looking at them. Okay, so this had a higher, this one, and so this patient is now advised completion thyroidectomy. So this can happen, we always have to tell. Another patient working in UK, she went with thyroid swelling surgery, as well as she had allergic rhinitis. This was a follicular neoplasm in the initial way, FNAC. So we did hemithyroidectomy. So this patient, I told you, she was in UK, we cannot follow up, but still I did hemithyroidectomy because it was a follicular neoplasm. Follicular neoplasm, the treatment is hemithyroidectomy usually. So I am not to be blamed. So, but final report came as follicular carcinoma with angio invasion. Mihir was the surgeon here, and we took a decision after tumor board that this patient had multiple vessel involvement. You can see that vessel involvement and capsular invasion. And finally, we decided to go ahead with the total thyroidectomy in this patient. And she will receive radioiodine. Both these patients will receive radioiodine therapy. So even if you do hemithyroidectomy, after all those discussions, there is still a possibility of conversion later. So beware. Again, a small, benign looking thyroid, large, long-standing one in a 60-year-old male, went ahead with hemithyroidectomy, and this was the report finally, oncocytic carcinoma, another little aggressive variant. Again, he also underwent the same process of completion thyroidectomy. Now, why we like lesser surgery is, I think everybody knows the reason. Lesser risk, lesser surgery, lesser hypothyroidism, and sometimes may not require thyroxine replacement. So there are few reasons. So that is why we do lesser surgery. Now, if you do hemithyroidectomy or total thyroidectomy, the guideline also says that you don't need to put a drain. We used to believe, okay, drain, meticulous draining. And when we realized sometimes some of these, two patients of us developed vocal cord palsy because of the traction from the drain. Because the patient initially was okay, then later had this problem. So Again, they also recommend, in the recommendation they have written, you don't need to put drains because it is not going to help. There are randomized trials trying to see whether you should put that drain in thyroid surgery or not. And they have found that it is of no use and you shouldn't put a drain in these patients. Now, can we do still smaller things? We can, because if there is an option of active surveillance in some of these patients, like my patient who had a high riding thyroid, high riding artery, the FNAC proven papillary carcinoma was only 5 millimeter. I told them, you don't have to worry anything. We can follow up this patient, follow up this nodule. But they were very, very much worried. So I think we have planned for surgery in that patient. I have not done that patient. But many of these patients, whenever we counsel them for active surveillance, they do not agree. That is the scenario that we see in our area, our country. But that recommendation says that if it is less than 1 centimeter, unifocal thyroid, intrathyroidal, without any clinical notes, we can do again follow-up. Again, this was from the Kuma Hospital experience. I think it was the Ito et al. And they have large series. Don't say that some of them may progress. Yes, some of them very little may progress. I think the progression rate is only less than 10%. But we have to be very careful. This was a meta-analysis also suggesting that we can follow up this patient. Now, I have only, I think, one patient. I think somewhere it would have been missed. It is there only. Only one patient whom we kept on surveillance. I have told surveillance to many patients, but many of them does not agree. At least they would say that we need to go ahead with half excision, at least hemithyroidectomy. That's how we go ahead. But one patient, this patient was diagnosed when she was pregnant in second trimester. So the patient had 1.5 centimeter. I told, okay, we can wait till, because it is only 1.5 centimeter, we can wait till the end of pregnancy. After 6 months, she came back with the kid. Again, it was 1.5 centimeter, not moved, not changed. I told, okay, maybe now you're okay, we can do surgery. But the husband said, we'll wait for some more time. So the decision was not mine, it was theirs. We again waited, so it is more than 1.5 years now. The nodule is same. So probably I think he will not come back, he will not be ready for surgery in the near future. So that is the only patient. Now, if we can keep some patients on surveillance, all these patients who are fit for getting a surveillance alone, that is, we are, even if they have a nodule which is papillary carcinoma with low risk, we can do what is known as thermal ablation. Not thermal ablation, ablation therapy. It can be various ways. It can be radiofrequency ablation or other modes of ablation. And this is again the new recommendation. They have clearly said in recommendation 11 that ultrasound guided percutaneous ablation may be considered as an alternative to active surveillance or surgery. And I think many of our friends from interventional radiology are taking up. And in north of India, many surgeons are also doing. I think if somebody is so fascinated, I think if we can, you can also take up this, and I'm sure we will get lots of patients. Because when you say surgery for a small thyroid, they may not like it, and if there is another option of ablation. But what is the problem with ablation is we do not know the long-term outcome of this therapy. So, but that is also possible. Now, the active surveillance I told you, and this is the patient whom I was telling that patient has been on follow-up. So, we have surveillance. If we are doing surveillance, it is by 6 monthly ultrasound scan, and if there is a progression, we need to intervene. So they should also understand that if there is a new lymph node in some area, we should be careful. We should go and stop and start doing surgery for this patient. If there is a growth of more than 3 millimeter, again, that's an indication for intervention. Evidence of extrathyroidal extension, And sometimes if it is going posteriorly, there is a risk of nerve involvement or the tracheal involvement. We should be careful in those patients. Other than that, we can do. So for small nodules, we have different options currently. Like these are the options which are available currently. One is do a hemithyroidectomy or lobectomy, or do a follow-up with ultrasound scan alone, that is called surveillance, and we can also do a percutaneous ablation. This is the new change that is there, has come in the guidelines. So I think it is, we can also practice. But again, if somebody says, I don't want to practice, that is also correct. Why? I think you can tell them. Huh? If I ask some PGs, they will get frightened. You already come to the... Because we don't have guidelines. Indian, there is no guideline. Okay, so when there is no guideline, nobody is going to force you. And when we say, what about ATA guideline, American, that's for Americans. Because they are driven by the insurance, and then that is why they have strict guidelines. I think we can, again, do and this. And we can adapt and then discuss and then give an option. I don't know what ChatGPT is saying, because now more than that, we should be worried about what ChatGPT or Gemini is saying, because only those lines will be taken up by our patients. So we should also be little wary of that. So I think I'll skip. Now, these are the scenarios in which we would again think of doing something lesser and lesser. I told you we are not doing surgery, we are sometimes following up. We are doing diagnosing papillary carcinoma and then following up. Now we should not diagnose at all. Then there is no tension, no? There is no headache. Now those are the situations that depends on the ultrasound scan. If the ultrasound scan says there is only low risk features like these lower things like a cystic mass, even if it is large, people say that you don't need to do. Don't do FNAC, don't do anything, you can just follow up. If it is little cystic, partly cystic, solid, etc., again, not required. But only when the suspicion is higher, like it is hypoechoic, solid. So that is why they brought in what is known as the TIRADS. Now again, this also has a caveat. എവിടെ നമ്മുടെ മിംസിലെ PG അവളോട് ചോദിക്കാമല്ലോ ക്വസ്റ്റ്യൻ അല്ലേ ഇക്കാലത്ത് ക്വസ്റ്റ്യൻ ചോദിക്കാൻ പാടില്ലല്ലോ സർ അങ്ങനെയല്ലേ സർ Right. What is that problem in this decision making? We should have a very good radiologist who will do. Americans will do the ultrasound or do the or send the patients to only thyroid ultrasounds sonologist. So that person will be doing only thyroid scans. So he is an expert. Here we get the neck ultrasound report from people who are doing obstetric sonology. That's the main work. And whenever we send, the neck is a part one. It's a part-time job. So that will not be accepted. So how much are they sure about their findings is a question. Now we are taking a big decision based on their report. Now how do we take a call on that? What I do is, whenever I read the report, the way their sentence is formatted, we can know that, okay, this person knows something. If they do not write anything about TIRADS, I will not look at the ultrasound scan only at all. Well, we will repeat it. So many a times it is better that we read up the report very nicely, and if you feel confident, only then take the decision of doing all these de-escalation things. So we have to be little cautious. Otherwise, we will be in trouble. Okay. So I'll just skip this and also say that we have, once we complete the treatment, we have some follow-up guidelines. I think everybody knows how do we follow up. I think I'll just tell about that then. Now, follow-up of these patients, we do what is known as the thyroglobulin, anti-thyroglobulin antibody, TSH, and calcium. This is what we do in all our patients on follow-up. And the recommended follow-up is 6 monthly. But I think by 6 months, people will forget the doctor. So that's why I keep them on 3 monthly follow-up. I think they are also happy, I'm also happy. Because more than that, they might miss the follow-ups. So 3 monthly, because at least TSH variations can happen over 3 months. And all these tests has to be done. If you have to do TG, anti-TG, we have to do TSH to monitor. Now this will tell, but TG and anti-TG we need to do only in 6 monthly. And that will tell us how the disease is going. And the recommendations clearly say that you have to do one stimulated thyroglobulin and one unstimulated. Or even if you do not do stimulated is fine, but unstimulated also initially, after initial treatment, that is within 6 months of treatment, we should do a thyroglobulin. Okay, and we should do a little bit of TSH suppression. That is, when we give thyroxine, we should give it at a little higher dose so that TSH is at a lower area. Especially in those high-risk patients, we should keep the TSH below 0.1. When there is an intermediate risk, we should keep it between 0.1 to 0.5. And if it is a low-risk patients, we can keep it at the normal level, that is 2, etc. And whenever the patient becomes pregnant, because many of these patients will be young ladies, if they become pregnant, we can keep them to a normal level rather than a suppressive level. So the guideline also is a part of de-escalation. They say that we can do a step down in this TSH suppression. This is again a new addition. How do we follow up? I told you I have been following up for 18 years. Not all my patients are coming for 18 years, but many of them are. And how do we follow up? When do they say tata bye-bye to them? Means to not to come to again, because they have to be cured. 10 to 15 years is the time that we say that, okay, that is the time that you are disease free. So, but that has been very strict again. Why Americans like to de-escalate is because they say that there is a financial toxicity available. I heard one of my colleague long back, he used to work in UK. So he said, in oncology. So he said once he was sitting in OPD, he had asked because oncology patients, they will ask them to come back after 3 months. He had asked to call up a patient, and this patient, because their registry will tell, this patient was living in some odd area in an island or something. So from the hospital, the helicopter came and picked him up and came back and did the follow-up. So that is the meticulous way in which they would do the follow-up. But our patients, and the whole amount will be borne by the government. But we don't have that. So that is why they say that we can even de-escalate in following up the patients. We can even do some of the low-risk patients, we can even say that at 5 to 8 years, your treatment can be stopped. So I think that is what we can do. So take-home message from this lecture, I think it's all, some of the low risk can be de-escalated is what I think you cannot read this because so that I'll skip again. I think that way I'll end up this session. I've not touched upon many of the areas. I've not touched upon all the areas in thyroid. I don't know how much time did I take. 30 minutes, 40 minutes? Okay, because usually these presentations, we will be very much worried about the timing. So I asked him what exactly, how much is the timing that he wanted. So he said, it's okay. Until the fellowship and dinner. Fellowship is there? It is there. So that was why I thought I will not look at the timing. I don't know whether I have made some sense to you, something which we have been practicing in head and neck oncology. Many of my colleagues, because I do go for meetings, for national meetings as well, and this is not my own practice, it is the practice which we as head and neck surgeons do at many of the centers in India. We can adapt and do things. I think I'll be happy to get opinions and more tips from our senior colleagues. Thank you very much, Surgeons Club, for inviting me. Thank you.
So topic is open for discussion.
Thank you, sir, for the nice presentation. My doubt is, after a hemithyroidectomy for a papillary carcinoma 2 centimeters, how will you follow up? What is the value of TSS suppression, thyroglobulin?
The patient, if the patient has undergone total thyroidectomy.
No, sir. Hemithyroidectomy.
Hemithyroidectomy.
Okay.
Hemithyroidectomy, 2 centimeter, we cannot do thyroglobulin. There is no point because we cannot follow up with thyroglobulin. But still, at the first visit, that is after the initial surgical problems are over, after 3 months when we call, because we will call the patient and do a TSH, because there is a chance that the patient may not get the full thyroxine T4 with the normal hemithyroid. So we need to check whether they are going into hypothyroidism. So TSH is a must after 3 months. Now, by the time, we should also ask for thyroglobulin. With the intact thyroid, the thyroglobulin will be little varying, but if it is very high, more than thousands, etc., then we should think of looking at the neck again. But if it is lesser, anything like 50, 100, etc., we know that it is not a bigger disease. And that patient, once that is done, we can follow up these patients every 6 months with ultrasound and TSH.
Will you put the patient on suppressive dose of eltroxin?
No, sir.
Only?
No,
So
no
just follow up.
suppression. For the suppressive dose for a normal thyroid is not recommended.
Okay. You are keeping the
Keeping
normal
them on
thyroid.
normal.
So the advantage is they can be off thyroxine.
Thyroxine.
Okay.
But again, can we say that because thyroxine as such is not causing any, if you see the literature, they say that maybe they can cause osteoporosis, thyroxine supplementation. But I don't know whether there is any strong evidence, because I have not read any literature on that, but some records say that there can be osteoporosis. Other than that, it is not causing any side effects. So I think giving thyroxine is not a major issue, but more than that, it is a complication that can happen. But then again, we'll say, okay, we are very good surgeons, okay, then what happened? So I used to think in this way, if it is my relative or my colleagues or this one, will I take that call? That is my question. Why I think so all of you will agree that whatever we do, I do meticulous micro dissection of parathyroids. That's what I do, because I use loop for all thyroidectomy. I will look at the parathyroids with the vessels. I would preserve them. But still, one patient, I could not find the parathyroid. Though there are so many adjuncts available, we don't have it now. This patient's, we removed, she developed into permanent hypoparathyroidism. When I look back, her thyroid, under the capsule, there were parathyroids. The pathologist said that there is a possibility that parathyroid location can be under the capsules. If by unluck your patient is there, that patient's life is a difficulty. So that is one big advantage of doing hemi. Just for a small 1 centimeter we do, and this patient develops. So she would keep coming, call me, and say, my hands are spasmodic, what do I do, like that. It's a mess. So that is one advantage, sir.
Excellent presentation. I have one doubt. Your case that carotid artery engulfed.
Sir.
Why should go such an extensive surgery instead of giving external beam radiation? Or can you do like that, external beam radiation and wait and see, or debulking and instead of going bypassing?
Nice question, sir. Nice question. That's what we said. The external beam radiotherapy does not have that much effect as radioiodine therapy. It does not have that much effect as a complete resection. So it is said, if we can do complete resection, go ahead and do it. That is the question. And I told you all these patients, their life has been normal. More than this patient, it would be that laryngectomy patient whom we should think. Now, this patient is entirely, one function is lost. Should you do a laryngectomy for a thyroid cancer? That could be, again, more, because it is going to be a life. Because the other patient is as normal as a normal, because he comes every 6 months. So, now, this question has been there. But what people say is, external beam radiation, no. If it is unresectable, like maybe carotid is one area where we can leave behind. Sometimes other stuck areas, if it is totally unresectable, then these patients can be treated with not radiotherapy alone. Currently, it is concurrent chemoradiation, because there are chemotherapeutic schedules which are available for thyroid cancers. But what we should do is, if it is unresectable, we would have done a biopsy, at least a part resection. In this, we have to do the molecular testing, whether there is an RET mutation, BRAF mutation, or NTRK mutations. And based on that, we have so many chemotherapy medicines. Along with that, chemotherapy as well as radiation can be given. I have seen one patient who was planned for laryngectomy, but then they were not willing. In that patient, we did this one. It was little 3 years back. So that time this chemotherapy schedule came only recent times. We didn't give chemotherapy, only radiation was done. But luckily her disease had regressed. But later she developed stridor, etc. Because there was slight progression, we had to do tracheostomy like that. So it is not a big thing. Now, radioiodine is a better tool than radiotherapy. Now, if that is so, which one will you give first? That's also a question always asked. Because if you give radiotherapy first, then these cells will not take up radioiodine very well. The vice versa is also, because if you give radioiodine, and many of these patients may be radioactive refractory, because that is why some of them will be very aggressive. So in that case, again, you will lose the time. So that question is also always there. But usually we would give radioiodine, then give radiotherapy like that. Unless they are high-risk patients, like areas like spine metastasis, wherein there is a cord compression and there is a high risk of cord compression, we would give radiotherapy beforehand itself. Otherwise, radiotherapy has little role. Of course, we can do it in unresectable tumors.
This is it's an excellent talk.
Thank you, sir.
So, my doubt is this: the risk stratification you said.
Sir.
Whether this risk measurement you can employ the molecular basis and like the RET
Yes,
and
yes,
RAS and other
that
things are there.
very happy to know that
and fusion and all those things
yes,
are there.
Sir, yes, sir, yes, sir, yes.
So whether that can modify
yes.
your the decision making.
Correct.
That is in favor of the total or the minimal procedure that you are proposed to do. So that's my question, whether that is that's not whether this can be included, and also that these investigations are being carried out here. It's being whether you can recommend.
Yes, sir. Yes, sir. Yes.
So just you were talking about the size of the tumor, extension of this the lesion, and even this histological pattern, everything that makes the risk stratification. So whether this, if we include the molecular the aspects also, it would be more comfortable and convenient, and that we can make a definitive opinion regarding this the further proceed.
Right. Now, there are so many molecular tests which are available now. Okay. Out of that, again, they do so many gene panels as well. Now, currently, they say we don't need to do it in all patients. I have one of my colleague who is an ENT surgeon. I did surgery for him, and then after surgery, I have been persuading him to go ahead with this mutation analysis. But what will mutation analysis tell us? We did surgery, we did radioiodine for him, but it will only tell you whether tell you the prognosis, whether you are likely to have recurrence or not. Now he knows it, and he said, no, I don't want. It is like knowing that you are going to have a recurrence, and then he will have to live with that fear. So currently they say you don't need to do these mutation analysis in all our patients. Now where do we use this? When we have an FNAC of a not so diagnostic FNAC like Bethesda 3 or 4, that is where this molecular testing can be done. The actual molecular testing that is done is, the original one is only available in America. The Afirma and the thyrogen analysis and the newer version of that, thyrogen 3, etc. And that is costly. I think 1.5 lakh is the cost. And Mihir always used to sell. Mihir, correct, na? Our one of the big shot, I think, Yusuf Ali only, correct, na? He had a thyroid swelling, and they had done when he was working in Lakeshore, they had done a molecular testing. They have sent it to US and then got it done. And then finally, it said nothing is there, no issue, no risk of malignancy. That's what. They will tell what is the risk of malignancy. If the molecular tests are positive, there is a risk of malignancy. You can go ahead with hemithyroidectomy or total thyroidectomy. Otherwise, follow-up. So I think he is under follow-up. Now, that is the only scenario where you can. Now, like everything, our Indians have copied many of these thyroid panels. But what people say is we cannot believe them. They are not original one, but still it is available. That was your second question. That Delhi and Bombay, there are various laboratories who does these gene analysis. They do 10 gene, 14 gene, etc. And they claim that it is a very good report. And the cost is around 25 to 30,000. In India, it is 25 to 30,000. So your surgery in a private hospital will cost 70 to 80,000 rupees. So instead of that, if you can spend 25, you may get a result and say that you don't need to. But if it is the other way, you will have additional expense. So that is a thing. But still, we can do. I have not advised for these kind of indeterminate nodules, but our colleague, interventional radiologist, does it regularly. So it is possible that we can do this test and make a decision making.
So the fear of de-escalation is about recurrence.
Recurrence, correct.
So what happens when a recurrence happens? You go and excise it and go do a radioiodine.
Correct. That is why de-escalation is there. Because even I told this large tumor which was there, they are still surviving. So there is the survival of thyroid cancers are very good. Even if they recur, we can give the same treatment. The recurrence can be picked up. Recurrence means what happens? Usually it is the nodes, because we would have done a good thyroidectomy at that time. So they might recur in the nodes. We will be meticulous in following up, and there will be a thyroglobulin elevation. Once there is a nodal recurrence, we can do neck dissection and give iodine therapy at that point of time. So then the nodal recurrence. Now, if you compare with other tumors like oral cancers, I have one patient whom we did, I think last year or 6, 8 months, last year, we did tongue surgery for a T2 N0 M0 tongue. I did surgery. We gave adjuvant radiotherapy because of various other reasons, because there was perineural invasion positive, etc. We gave radiotherapy, but the patient recurred with node. Now, this patient's survival is affected. If the patient without node, if after treatment, if she was supposed to survive for 5 years, her survival is now reduced with the presence of node alone. Her chance of surviving 5 years is now around 50% only. Otherwise, it would have been 80 to 90%, became 40% to 50% now, with the presence of node. This scenario is not there in thyroid cancers. Thyroid cancer, even if there is a node, they will survive without much issues. We just have to give the therapy to these patients.
That means we can take up the de-escalation more boldly.
Yes, more boldly. That is why that is. But only thing is, we should discuss with them. They should understand, and they should be coming for follow-up.
Sir, after surgery, when we send the patient to nuclear medicine, most often we get a report that there is significant amount of residual thyroid tissue in thyroid bed. So what is that significant amount according to their criteria?
We are still.
Would you recommend ablation based on that? Or
we are still researching on that. Okay, we have not found what is that thing. We have had so much of arguments. I have, when they said like that, I have done CT scans, ultrasounds to find out what exactly is the residual thyroid, but we have not found it. So probably it is the way I think they have been taught. I don't know whether it is there. They say that microscopic uptake is there, but only if cells are there, there will be uptake. We are sure that there are no cells. So what I have stopped sending those low-risk patients. If we send, they will have this report. And then with that, they will convince. Because it is a very good, nice picture, no? They, something is there, and then you should get ablation. So I think if you are sure that low risk, I've not sent so many patients, and they are under follow-up, there is no issue. And as such, hemothyroidectomy patients do not go at all. I have about 32 patients for the last 5 to 2017, etc. I started, maybe around 8 to 9 years on follow-up with hemothyroidectomy alone. Until now, they have not got a second surgery. So I think it is possible. It is better that if you are sure, low risk, not send. You have a better modality. See, there is a terminology called tennis, correct? What is it? Thyroglobulin elevated negative iodine scan. But there is no reverse scenario, wherein thyroglobulin is normal, but there is a positive scan. That is never there. So why should you worry? You always have the thyroglobulin at your hand, which will tell you about the disease. But remember, thyroglobulin and anti-TG antibody, because I have one patient who was operated outside, then came back with nodes. We were following up. The thyroglobulin was normal, but TG was little higher. She had a node. TG was higher. Because of the presence of antibody, the thyroglobulin value will be suppressed. So beware of that. So always do both. And if that is both are normal, I think we can follow up these patients. Dibit.
I will not take much time. He is okay. Sir is basically not a head and neck surgeon. He does everything. I know him from Malabar Cancer Center. But our topic is just de-escalation coming to thyroid surgery. I had few doubts. Means most of the surgery colleagues will ask me if there is a thyroid swelling, and most of our ultrasound reports will come as few 1 centimeter node on bilateral side, cori, meds, cori. We will not be able to FNAC all the nodes. So what will be your take on management of such patients with lateral node?
Okay, good. Another good question. Again, because we don't have a specific sonologist who are looking into neck alone, we will get these reports every time. Because there are so many inflammatory nodes in many of our people. So they will say absent hilum, cori hilum, etc., etc., etc. So what we do is try to, if there is palpable, surely we will do FNAC. But these doubtful ones, we will try to do FNAC. If that is not possible, what we usually do is, during surgery, we will do a frozen section. We have the luxury of that frozen section. So we do a frozen section and then see that whether we need to do. Because thyroid, the node will be on the same side, same side. It is very easy to take a node for frozen section and then go ahead, than do an FNAC. But why we do that is because the indication for doing a neck dissection is only in an biopsy proven, that is, or FNAC or biopsy proven neck nodes. There is no role for prophylactic neck dissection in well-differentiated thyroid cancers. And in follicular carcinoma, there is no role at all. Papillary, yes. Oncocytic, yes. And what is there more is in medullary carcinoma. Beware, if what I have talked is all about well-differentiated thyroid cancers. If it is medullary thyroid cancers, there is a role for prophylactic neck dissection, and the surgeon is the risk factor for medullary carcinoma. If you do the surgery at the first surgery very well, the patient will have very good result. If you mess up, then the patient will surely have problems. So medullary, we have to be really careful. Do prophylactic neck dissection if required, but for papillary, well-differentiated, do not do without an FNAC proven or a frozen section that like we do.
And that's the thing, there is no role for prophylactic unlike medullary. And second thing is that there is something called as ipsilateral central compartment.
Correct.
Bilateral compartment. So will you prefer doing an ipsilateral central compartment for somewhat you feel intra-op risk, or you will prefer to do a central compartment entire if you doing a prophylactic central compartment? Is there any recommendation?
That's a tricky question.
But I used to practice ipsilateral, or something called as ipsilateral.
That's a tricky question because I do not have an answer to that, because there is no literature supporting that. But there are people who suggest that even hemithyroidectomy with ipsilateral central neck dissection can be done in small node positive patients. Like you have 1 or 2 central neck nodes, Even a ipsilateral neck dissection is done, that is good enough, and then you can even not give radioiodine and follow up this patient. But I am little wary because, why? Because in those patients where we knew that there is a central compartment, when we do bilateral, we have seen that some patients do have nodes on the other side. So if you are confident of doing an ipsilateral, as well do it bilateral. Hypoparathyroidism is a problem, but then you have to bear with it because you are dealing with a little more. Because today I saw a follow-up patient whom we did a lateral compartment neck dissection and central compartment. She had 22 nodes positive. So the likelihood of missing in these kind of patients who has 22 nodes is very high. And you know what happens if there is central node recurrence? We don't want that. So it is better that we take up this.
And the final question is, all these are mostly practical things we come to. Most of the time we will do a thyroidectomy without knowing the biopsy, and final HPR comes as a papillary carcinoma. And as Sar told, most of the time it will be telling that there is a significant residue. So I'll give you, sir, for practical purpose, for their help, I'll give two scenarios. One is there is a significant residue in the thyroid bed. And another case, there is a significant residue. We have practically, tomorrow one case is that there is a significant residue in the thyroid blood and with a 1 centimeter node having an uptake. Will you go for surgery in both cases, or will you prefer only in one case? What is
you did the surgery or your resident did the surgery?
That's immaterial, sir.
No, it is material because you know how much completion of surgery has been done. If you have done a subtotal or a near total thyroidectomy, in a benign tumor, it is accepted. Wherein if there is a risk for nerve, etc., you might be okay with it. And final HPR came as this one carcinoma. You know that you have left behind some thyroid. In those patients, remnant ablation is a method. Now I said remnant ablation because even ablation is not a common word advised. The ablation is if you have a remnant thyroid tissue, like in this scenario, you call it remnant ablation. If you have a distant metastasis, I'll add those points in between. If you have a distant metastasis, this is called a radioiodine therapy because you are treating this patient, the distant metastasis, with radioiodine. Okay, that is not called ablation. It is called radioiodine therapy. And if you are sending for high-risk features wherein there is no disease at all, but to prevent recurrence, prophylactic radioiodine, you call it adjuvant radioiodine therapy. So these are the three terminologies which has been advised. So don't call everything as radioiodine ablation, okay? So now in this patient, because there is a residual thyroid, because you know you have left behind, do a radioiodine ablation of the remnant thyroid and then do the thyroglobulin. If it is low, you get a biochemical cure. Again, there are classifications for biochemical cure or not cure, etc. In that case, follow up the patient. Now, second scenario, you have done a total thyroidectomy, but unluckily, you have a 1 centimeter node. That patient, it is better that you go ahead and do the neck dissection. But practical scenario, I'll tell you. I have also done that. The patient, that is how we do, like after the surgery, we will keep the patient with off thyroxine. We will not start the thyroxine. We will keep them off till the HPR comes. By the time it will be 1 week, 10 days. Then by the time we do TSH, it will be a little higher. And the HPR says total thyroidectomy. And then maybe if there is a risk, we'll send for iodine scan. So patient is already hypothyroid. Now you cannot do surgery when the patient is hypothyroid. So better modality would be ask them to undergo radioiodine therapy. Okay. Now, after radioiodine therapy, in the next follow-up, after 3 months, check the thyroglobulin, do an ultrasound, see whether this node has gone away. If the node has not gone away or increased in size, then do the neck dissection at that time. Rather than, because iodine therapy might clear them, no? Because microscopic nodes will respond to radioiodine therapy. But gross nodes will not respond to radioiodine therapy. Why? Because the sodium import, iodine import is less in nodes. So iodine will not take up in these nodes. So they are high likely that they will not respond to radioiodine in this larger tumor.
That's only take home like nodes are very tricky. Will they respond or not is we cannot predict.
Usually
so
doesn't.
node maybe we will do a resurgery. For other things we can
Correct.
Thanks.
Sir, one question for the knowledge of PG, sir. So you just mentioned about the tennis. How will you manage tennis?
Tennis, if the more than tennis, now they call it as radioactive iodine refractory, rare. That is what they call now, rare disease. Rare disease more falls into surgical aspect whenever possible, because if a tennis patient comes with a thyroid bed swelling or a neck swelling, paratracheal node, these are the usual scenarios. We should resect if whenever possible, because iodine is not going to work. But if they have so many lung metastasis, they have bone metastasis, or very inoperable disease scenario, or local with the neck, we have something called the TKIs which we can give. That is tyrosine kinase inhibitors. Mainly what is given is lenvatinib, and these works in these kind of patients.
Diagnosis by
Diagnosis by a PET scan. PET scan or even CT scan of the neck, thorax, etc. as per the scenario. But usually we would advise PET scan in these patients. And wherever resection is possible, we will go ahead. When resection is not possible, or if it is even after resection they are progressing, like new lesions are coming, we will give lenvatinib and I'm not getting that word, which is the regenerative, redifferentiation, sorry. It is called redifferentiation theory, wherein this tennis happens because of undifferentiation, correct? Because that happens over years, and this lenvatinib or tablets can give redifferentiation, and then after some time we may have. But these all came up recently. We have started using it recently only, so we do not have too much of experience to say that they will convert back to iodine therapy. But I think we have been hearing it from others in the other world, and they say that it works.
No
you also know that, I'll just add on that, anaplastic thyroid cancer is treatable now, no? I think everybody knows it. Surgery as well as neoadjuvant therapies. Surgery is only if it is operable, we have to do surgery. If it is inoperable, we have to do neoadjuvant chemotherapy, and then, neoadjuvant chemotherapy, chemo. And then we have to see the mutations and then give the therapy. And then if it is, again, RET, etc., they have molecules based on that. And then follow up, if it becomes operable, then operate, then give adjuvant radiotherapy. They have good survival. I have one patient whom we have treated, and she is surviving for more than 15 months now. And it was never heard of. We'll hear they die within 6 months. But this is the first time that we.
Thank you, sir, for the.
No, sir, no. Then it will be very difficult to operate on that post-radiation patients.
Thank you, sir.
Thank you very much. Thank you.
Now I invite Dr. P.G. Monda, sir, to present the memento to Sajid, sir. I invite Gobi sir to present memento to Umar Fadil. I invite Joji sir to present certificate to PG President Anshi. Now the vote of thanks. First of all, I would like to express my sincere thanks to our respected senior faculty members for their presence and valuable guidance. I extend my heartfelt gratitude to our guest speaker, Dr. Sajid sir, to give a clarity for the management of papillary carcinoma thyroid. I would also like to express my gratitude to Dr. Umar Fadil for his excellent presentation. It was truly inspiring for many of seated here. My sincere appreciation goes to our PG presenter, Dr. Anshi, for her confident and well-delivered presentation. I would also like to extend my sincere thanks to our sponsors, Torrent Pharma, Stella Division, for their generous support in making this program a success. Many of you familiar with this, their drug, Tabilobetra, used for the management of chronic constipation, also in post-operative cases also. Thank you, Arjun, for your support. Finally, I thank all my friends, teachers, colleagues, and PG students for their active participation and support. Once again, thank you all. Now we shall conclude with the national anthem. जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गादा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे. The meeting is adjourned for dinner and fellowship. Good night.